All right, let's unpack a really powerful and, well, still evolving therapy in IR today. We're doing a deep dive into Y90 hepatic radioembolization, TAR.
Yeah.
It's one of those treatments where we really need to function almost like interventional radiation oncologists, moving it way beyond just salvage therapy.
That's absolutely right. The goal today, I think, is to really distill those key insights and maybe some of the nuances, the things that take it from a standard procedure to something really cutting edge and patient specific.
Yeah.
Looking at what's actually like moving the needle on outcomes.
Okay, so let's start foundational. Why TAR? Why the liver? It boils down to that unique dual blood supply, doesn't it?
Exactly. The tumors, whether they're primary HCC or METs, they are overwhelmingly fed by the hepatic artery, which is perfect for us, right? It lets us deliver those Y90 microspheres preferentially. High tumor dose, spare the normal tissue.
And Y90 itself is pretty unique. Pure beta emitter.
Pure beta, yeah. And that's critical. The radiation range is incredibly short, average, 2.5 millimeters. It means really intense, localized radiation right where you want it with minimal scatter. That limited range is why it's safe for outpatient settings. It's really the cornerstone of the safety profile.
Then you've got the different spheres, glass, like Therasphere and resin Suraspheres.
Right.
What's the practical difference there? Beyond just, glass and plastic, how does it affect what we do?
Good question. It's physics, really. Glass spheres have a much lower particle count, so they pack a bigger punch per sphere, if you like. Great for when you want a really focal high dose, like an ablative segmentectomy kind of goal.
Right, hitting it hard in one spot.
Exactly. Resin, though, has a much higher particle count, millions more, so you get a more sort of uniform distribution, better maybe for diffuse disease. But the catch is that higher particle load means a greater risk of causing flow stasis during the injection. You have to be super careful.
Okay, that makes sense. It's a trade-off.
It is. Precision versus distribution, almost. It really dictates your injection technique.
And while we're on devices, Holmium-166. It's approved in Europe.
Right.
How does that fit in? Is it a game changer?
It's very exciting. Holmium's different because it's beta and gamma. That gamma emission means you can actually image it directly after treatment with SPECT or even MRI. So you get true see what you treat verification. You're not relying on MAA as a surrogate anymore. That's a big leap.
Which brings us nicely to the pre-procedure stuff, the mapping angiogram. You called it the dress rehearsal. Why so critical?
Because that's your chance, your only chance sometimes to find those small, dangerous connections. Hepatoenteric vessels.
Yeah.
You need super selective catheterization and often a higher injection rate, maybe 2-3 milliliters per second. You almost want to induce a little transient reflux carefully just to make sure you see everything that could lead to non-target embolization.
And the MAA scan that follows. Not just for lung shunt anymore.
Oh, definitely not. SPECT-CT is the standard now. Yes, you get your accurate lung shunt fraction, but crucially, it gives you precise anatomical localization of any extrahepatic uptake. Stomach, bowel, pancreas. This underpins that whole confirm then coil philosophy. We don't just prophylactically coil the GDA anymore. We confirm uptake, then we coil if needed. Much more targeted.
So all this meticulous planning, how does it translate into dosimetry? We've moved way past the old empiric methods, right?
Totally. Personalized physics-based planning is where it's at. The partition model is key. It lets you calculate separate absorbed doses. What's the tumor getting? What's the normal liver getting? And the goal now, especially with curative intent, is often ablative doses. You're talking over 205 G for HCC response, maybe 400 G or more for a complete segmentectomy ablation.
Wow, those are high numbers. But you have to watch the normal liver dose.
Absolutely critical. Your NLD limits, generally under, say, 40 to 70 G paper resin, maybe a bit higher, 70 to 120 Richter for glass. You have to respect those. And sphere count itself is another variable. Sometimes fewer spheres for a really hot focal spot in a hypervascular tumor, more spheres for diffuse or hypovascular stuff. It's all getting very tailored.
Okay, let's talk procedure. Access. Radial versus femoral. TRA has patient preference, but downsides.
Yeah, TRA is great for patient comfort, quick ambulation, but it often means longer fluoro times. And sometimes, depending on the anatomy, getting good cone beam CT images can be trickier from the wrist. So TFA, femoral access, is still the workhorse for many. Often easier CBCT, potentially less fluoro, just means the patient lies flat for a bit longer after.
And injecting the spheres, you said it's device specific?
Very much so. Glass spheres tend to settle, so you often need a more forceful kind of pulsatile injection technique to keep them suspended and moving. Resin, because of that high particle count and stasis risk, is the opposite. Slow, gentle infusion, constant fluoro monitoring, little contrast puffs intermittently to check flow, and you have to be ready to stop immediately if you see any hint of stasis. Using D5W as the diluent helps too, less viscous.
Makes sense. And advanced techniques.
Yeah.
Radiation segmentectomy, lobectomy.
Huge. These are really changing how we use TAR. Radiation lobectomy, for instance, to induce FLR hypertrophy. It's fantastic because you treat the tumor and prepare the patient for potential resection simultaneously, killing two birds with one stone.
And cone beam CT during the procedure.
Oh, CBCT is transformative. Real-time 3D anatomy right there in the suite. It lets you definitively assess any extrahepatic perfusion you saw on the angio, guides your coiling precisely, and then you can do a CBCT right after injection sometimes to confirm tumor coverage. It's invaluable. Even simple things like making sure your catheter tip is well away from a bifurcation, ideally more than 20 millimeter, can really help optimize flow dynamics.
Okay, wrapping up. Post-procedure imaging and avoiding the bad stuff, complications.
Post-treatment imaging Y90P TCT is far superior to the older Bremsstrahlung SPECT TCT. It actually shows you where the dose really went, allowing for proper voxel-based dosimetry after the fact. Closing the loop. And complications. Honestly, the most severe ones, GI ulcers, radiation-induced liver disease, RILD, they are largely preventable.
How?
Meticulous mapping beforehand, using CBCT not just for anatomy, but functional assessment of shunts. Strict adherence to those personalized dosimetry limits we talked about. It's all about the prep and planning.
So it really has evolved, hasn't it? TAR isn't just a last resort anymore. It's demanding we think differently.
Absolutely. We have to understand radiobiology, advanced imaging, complex angiographic techniques, the whole package. The goal is safe, effective, and increasingly truly curative treatment delivery.